I think he's joined.
हेलो हेलो। हाँ जी जी जी।
Okay, so good afternoon, everybody, and welcome to the MedEClasses MedEClasses quiz. This is the fifth event that we are going to organize, which is usually an annual quiz, in which we have got two important components. One is the basic quiz, in which we are focusing on the key aspects of pediatric endocrinology relevant for pediatricians, and then we have got the advanced one, in which we are focusing about more advanced topics from that perspective. And it is indeed a pleasure. It was a very well conducted quiz in which we had got a lot of clinical questions and queries which were there, and it was participated from participants across the world, and including different parts of India and beyond. And it was a very, very interesting program overall from that perspective. So we will be starting off with regards to our basic quiz first, and we have got the various participants, and we'll start with introduction for each of them. So we have got Dr. Rashmi Nagaraj, who is Professor at JSS Medical College, Mysuru. Dr. Rashmi, please. Dr. Rashmi has been long associated with our team earlier as well. Yeah. Please introduce yourself. Yeah. You are muted. Yeah.
Hello everyone, I'm Dr. Ashmi. I'm Associate Professor in Pediatrics, JSS Medical College Hospital, JSS Academy of Higher Education and Research. I have been taking medical classes since 2018, and it's a pleasure to be here, and it's a privilege too. So thank you, sir, for this opportunity. So, and good luck for all the participants.
Thanks a lot, Dr. Rashmi. We have got
Thanks.
Dr. Anupama K. Yadav, who is from Nepal, from Kanti Children's Hospital. Dr. Anupama, please introduce yourself.
Good afternoon, everyone. I'm Dr. Anupama Yadav from Nepal. I'm currently working at Kanti Children's Hospital, which is located at Kathmandu, and I'm assistant professor.
Okay. We have got Dr. Vishal Thakkar, Dr. Vishal from Kilol Hospital. Dr. Vishal, please introduce yourself.
Good afternoon, everyone. I am practicing pediatrician at Gandhidham, Kutch, Gujarat, and I got the opportunity to learn from sir, and I got the guidance from Dr. Chetan Dave sir and Dr. Riddhi Patel, who has done fellowship under Dr. Anurag sir, and I am lucky to get the knowledge from the sir.
Thank you, Dr. Vishal. We have got Dr. Ananya from JSS Mysore. Dr. Ananya, please introduce yourself.
Good afternoon, everybody. I'm Dr. Ananya. I'm a second year PG resident at JSS Medical College, Mysuru. I'm thankful for this opportunity, like as I've got to learn from the clinical scenarios which was given in the quiz, and excited to take part in the quiz and wishing good luck to all of them.
Thank you, Dr. Ananya. We have got Dr. Sania Kausar. Dr. Sania is from KGMU. Dr. Sania, please, could you introduce yourself?
Good afternoon, everyone. I'm Dr. Sanya Kosa. Currently, I'm third year pediatric resident at King George Medical University, Lucknow.
Thank you, Dr. Sania. We are waiting for Dr. Kedarnath, but we'll start off and hopefully he'll join by the time the quiz starts. Otherwise, Dr. Salik is there, so he can put his inputs as well. He's for the advanced, I think, program. So we'll, Sir Dr. Salik, how are you?
Good afternoon, sir. Fine, sir. Yes.
Okay, no worries. So I'll request all the participants to be in mute unless and until the question is directed towards you. So we'll start off with the overview of this program, and we'll go forward from that perspective. So We would like to definitely, MedEClasses has been working towards increasing awareness about pediatric endocrinology and different aspects of pediatric endocrinology. We have been conducting a number of workshop programs to begin with, and then we carried forward with regards to our practical pediatric endocrine courses, further traveled in terms of our social media interaction to highlight the issues in terms of pediatric endocrinology, our fellowship program, and we talked about Dr. Chetan and Dr. Riddhi, who are here in our fellowship, which was 2017. Then we started off with our MedEClasses, which was a learning portal, because we realized that unless we have a structured program, it would not be appropriate to go forward on that, and subsequent books are there. So there's an e-learning portal which has got huge number of videos and covering entirety of pediatric endocrinology, and this also is currently going live on YouTube with regards to these quiz as well. We have got a structured learning program with validated tools in the form of MedEClasses. We have got specific programs for fellowship and pediatric endocrinology for postgraduates. There are publications which are available of pediatric endocrinology protocols, basic, and we are coming up soon with a second edition of our advanced pediatric endocrinology in a month from that regards. We've got a mobile application which helps out in terms of assessment and management. So the basic pediatric endocrine quiz is basically one which is directed towards pediatricians and pediatric trainees. So this quiz covered all the questions this time were entirely clinical based. And we like to thank Dr. Kirti, Dr. Ria and Dr. Sayan, who did a very important job in terms of creating those questions. And it was, as said, participated from across the country. Now, based upon that, we had these finalists who have joined us today. And the finalists that we already talked about include Dr. Rashmi, Dr. Sania, Dr. Anupama, Dr. Vishal, Dr. Ananya, and Dr. Kedarnath, who have joined to us. The first prize for this quiz would be a basic pediatric endocrine course online and on-site. Then we have got second prize for adolescent endocrinology course, and the finalists will be getting other prizes. There will also be audience prizes, so audience will be requested to join and write in chat options from that perspective. So this quiz basically has got 5 rounds. There will be 4 direct rounds in which you will be asked questions directly, and they will then pass in the direction, and these will be in reverse direction in the second round. So the first round, it will go from 1 to 6. The second will go back from 6 to 1. Then after 4 rounds, there will be one buzzer round. So 10 marks if you get the answer correct for direct and 5 for pass. 15 seconds will be given for answer, and there will be only one answer. So be very, very confident when you are answering. Do not answer unless you are sure about that. And quiz master's decision will be obviously final in that perspective. So the first round would be make the diagnosis. I hope the thing is clear from all perspective for everybody. So we can start off with the questions from there. We'll be starting from Dr. Rashmi. The first question will be targeted to Dr. Rashmi. So Dr. Rashmi will be the one, candidate 1. Then Sania will be 2. Dr. Anupama will be 3. Dr. Vishal, Dr. Ananya, and Dr. Kedarnath from round 1. And round 2 will reverse from Dr. Kedarnath to Dr. Rashmi. So we'll start off with the first round, first question, and this is about making the diagnosis. And we know that in pediatric endocrinology, if you make the diagnosis, often you have specific treatments which are available. So we have a 2-year-old girl with failure to thrive who has got rickets. Calcium is 9.1, phosphorus is 1.8 milligram per DL. Alkaline phosphatase is 1200 and urinary glucose is positive. So we have got a girl with failure to thrive and rickets with low phosphate, high ALP and urinary glucose, which is positive. What finding are we seeing here in this particular picture, and what is the most likely diagnosis? So Dr. Rashmi. Dr. Rashmi?
Yes, sir. Yes, sir. Yes.
So what do you think is the diagnosis in this case? Girl with failure to thrive, rickets, calcium is normal, phosphate is low, ALP is high, glucose is positive.
So there's a coloboma in the iris is Alport syndrome.
No, that's not the right answer. So we'll pass it to Dr. Sania.
Cystinuria.
Cystinuria. Okay, and what are you seeing on the eyes? We'll pass to the next one and see if we have a better answer for that. Dr. Anupama.
Sir, is it glaucoma in as in Lewy syndrome?
No, we'll pass to Dr. Vishal.
Pass, sir.
Dr. Ananya.
It's 1.9.
Dr. Ananya, you like to answer?
Pass.
Dr. Kedarnath.
Sir, it is looking like nephropathy calcinosis. That might be a Fanconi syndrome.
No. So I think we'll go back to Dr. Sania. What was your answer?
Cystinuria.
Cystinuria. So we'll give you, I think it is cystinosis. Since nobody else has answered, this is corneal crystals. And this is a classical case of proximal RTA, Fanconi syndrome. And we have got this corneal crystal and cystinosis. So this is the clear-cut picture, which we wanted to get the answer. So since you have given the answer, we'll give you 5 marks to Dr. Sania in this regards. So I think that was a good answer. So this is classically a case of proximal RTA. If you look at it, I've given a clue for glucosuria, which is there. Whenever you find anybody who has got a proximal RTA, always start thinking of some other possibilities which are there in that regard, and that becomes important to identify. And clearly what we are seeing here is that this was a corneal crystals which were there on slit lamp examination. So now we'll have the next direct question, which is to Dr. Sania. 4-year-old boy with jitteriness, calcium is 6.4, phosphate is 9 milligram per dl. PTH is 2 picomole per liter, and this is actually a refrigerated sample, so there is no confusion that there is a problem in terms of transport. There is small jaw and there is a low set ear that we are seeing out in that perspective. Now, this is the picture of the child. Now, the question is very simple. Which cardiac defect is most likely to be observed in this condition?
Pulmonary stenosis.
Pulmonary stenosis. And what do you think is the diagnosis here? Okay, we'll move forward. Dr. Anupama.
This is DiGeorge syndrome, sir.
DiGeorge syndrome. And what is the most likely cardiac defect?
Tetralogy of Fallot can be seen.
Tetralogy of Fallot. Anything specific?
Or interrupted aortic arch.
Okay, so we'll give you the answer there. So this is DiGeorge syndrome, and interrupted aortic arch will be one of the most common findings that we are giving. So 5 marks to Dr. Anupama on that. Now we have got a direct question which will go to Dr. Anupama. A 4-week-old girl with polyuria. She had a birth weight of 1800 grams. So SGA, current weight is 1400 grams. Blood glucose is 360. And there is no ketone. So there is no ketosis. There is only hyperglycemia. And this is the finding you found on clinical examination. The question is very, very specific, and it is asking what is the likely clinical course in this condition. So 1800 gram at birth, 1400 now with hyperglycemia, non-ketotic. What do you think is the course of this neonatal diabetes?
So the child might develop increase in weight, and it is likely genetic condition.
It is genetic. Most neonatal diabetes we always talk about is genetic in that regard. What I'm asking is there is something specific that we are finding in the ear. Can you notice something that is there in the ear? And
Yeah.
what do they predict?
Is it ear crease, sir? Beckwith-Wiedemann?
There is a ear crease, but Beckwith-Wiedemann causes hyperinsulinism. So we'll move and see what somebody else has a better answer or not. Dr. Vishal? So
Pass,
there
sir.
is a key. And there is the neonatal diabetes with ear crease. These two things we know. Dr. Ananya?
Pass.
Dr. Kedarnath? Dr. Kedarnath? Dr. Rashmi? Dr. Rashmi, would like to volunteer an answer? If not, you can just say pass. So that we can go forward to the next person.
Pass.
Finally, Dr. Sania.
Pass, sir.
So this was a direct question to Dr. Anupama. She did mention that this is a year 3, so we'll give her 5 marks. But the main point was that if somebody gets a ear crease in neonatal diabetes, this is most likely an imprinting disorder. It's not Beckwith-Wiedemann, but something like an imprinting disorder, which has a very high chance of remission. So this is going to be a transient form of neonatal diabetes that we are talking about. So this is most likely a transient neonatal diabetes that we are looking at. A 6-week girl with irritability. This question is directly to Dr. Vishal. Serum calcium is 12, phosphate is 8, PTH is undetectable. So hypercalcemia, high phosphorus, and what are we seeing here? This is the X-ray finding of this child with hypercalcemia and hyperphosphatemia with low PTH. Now, the question is, with a very, very simple test, we were able to make the correct diagnosis in this regards. Dr. Vishal, what do you think is the diagnosis here?
Vitamin D level, sir.
Vitamin D levels were normal. So this is hypercalcemia with hyperphosphatemia. Vitamin D was normal, but what we are seeing is very specific in the bones, if you look carefully. And simple test gave us an answer. Routine test, which we do every time. So we will then move forward to Dr. Ananya. Dr. Ananya, would you like to guess on this one? Hypercalcemia with hyperphosphatemia with low PTH. And the X-ray finding.
Osteitis fibrosa cystica.
Your voice is a bit less. Can you please speak a bit louder?
Sir, I think the diagnosis is osteitis fibrosa cystica, fibrous tissue on the bone.
Okay, no, we'll move forward. We'll move to Dr. Kedarnath. Dr. Rashmi.
Serum alkaline phosphatase?
What will you tell you, Dr. Rashmi? What are you thinking of? So you have got high calcium, high phosphate, and low PTH, and the bones are.
Yes, sir.
So what are you thinking of? Low
It's
ALP.
looking like marble bone disease, actually.
Okay. Maybe we'll go further to Dr. Sania.
Is it subcutaneous fat necrosis?
No, it's not subcutaneous fat necrosis. Dr. Anupama?
Sir, is it metabolic bone disease? Because
No. So I think it is alkaline phosphatase, but unless and until we get the right, I think the logic would have been very important, because what we are looking at is high calcium, high phosphorus, which means it is a decreased bone formation state. So all the calcium and phosphorus is in the blood. It is not getting deposited in the bones because bones are not getting formed. This is a case of hypophosphatasia, where the alkaline phosphatase levels are going to be very, very low. So we will unfortunately not give the answer for that because we wanted a specific reason why we are talking about ALP on that regard. So this was hypophosphatasia. We'll move forward to the next question. 6-year-old girl with precocious puberty. This is for Dr. Ananya. And breast stage 3, pubic hair 2. There is no periods yet. Height is slightly advanced. Weight is normal. LH is 1.2. FSH is also 1.2. Estradiol is high. So this is a case of clear-cut precocious puberty. And when you do the examination, you find this on clinical examination. So what do you think is the most likely diagnosis here? And what is the underlying condition? This is to Dr. Ananya.
So this is a cafe au lait spot.
Yes. Diagnosis?
And my diagnosis is McCune-Albright syndrome.
Okay. Next we go to Dr. Kedarnath. We'll move to Dr. Rashmi then. Dr. Rashmi would like to answer.
Pass, sir.
Okay. Dr. Sania.
The neurofibromatosis was due to optic nerve glioma.
Yes, I think this is what we're looking at. This is actually a cafe au lait spot, but our LHFSH is high. So if you look at the type of cafe au lait spot, this is also not fitting into the McCune-Albright. This is looking more like a regular margin, smaller size, and we have a central precocious puberty. So this is the correct answer. So I think that was a very good answer. We'll give this to Dr. Sania. This is actually the correct answer from that perspective. So we'll move to the next question. Next question, I think Dr. Kedar is not there. So we will give this, we'll add these questions to the other persons as well. So this will become a direct question to you, Dr. Rashmi. Dr. Rashmi, this is a direct question to you.
Yes, sir.
14-year-old boy with tall stature, height is 182 centimeters. There are visual defects. There is a downward lens dislocation. Now, this is very important. I'm saying downward lens dislocation. Now, this child had a sudden catastrophe. So, what do you think would have been this most likely life-threatening complication that this tall boy with visual problems and downwards lenticular dislocation could have happened?
So it's a acute stroke,
Yes, in the setting of?
homocystinuria.
Okay, so this is a perfect.
In the setting of homocystinuria.
Yes, yes. So we will give you the correct answer. This is 10 marks to Dr. Rashmi. And we should remember that we've given extra question, direct question, Dr. Rashmi. So everybody will get an extra question directly. I think that was a perfect answer from that regard. So we'll give 10 marks to Dr. Rashmi. So Dr. Kirti, what is the score? You can come up and tell the scores. After the first round. So this was an interesting one. Hope all of you are liking the round.
Thank you, sir. So after the end of first round, we have Dr. Rashmi with 10 points, Dr. Sania with 10 points, Dr. Anupama with 10 points, and Dr. Vishal, Dr. Ananya are yet to be.
Okay, that's good. So I think this was a good round to begin with, and we tried to spot the diagnosis. We got a very interesting question for the audience as well. So the next question is for the audience, and I think the chat, you can access the chat. And I'll request all the audience to put the answers in the chat immediately once you get the answer, and we will know which person has done it for the first, has done it fastest. So this question is a 3-year-old boy with short stature. Height is minus 4.4 standard deviation score. Weight is minus 2.14 standard deviation score. So both are affected. This is the child, and what you can see is that there is a big liver facies is appearing like this. There is a massive hepatomegaly. There is glucose of 20, ketones of 3.2. Now, lactate is also 1. The question is, what is the most likely diagnosis? So now the audience can put the answer. I think we've got one answer in the chat already. So who has given the right answer? So what is the answer maybe? Dr. Shams, I'll request all the advanced quiz people to not answer the questions. Yeah, anybody else is coming? Yeah. So all of them have answered. So I think the correct answer is GSG. So after Dr. Sham Sundar, we have got next person is Dr. Abhishek. Dr. Aisha. Dr. Aisha from Libya. She has answered the correct question correctly. So she is the audience winner for this particular round. So you can note that as well. So we'll now move forward to the second round. So this diagnosis was, so what we're looking at here is a child coming to us with short stature and hepatomegaly. When we see the glucose is very low, there is ketotic. So we thought that this could be GSD, and this was proven from that perspective. So after round 1, we are aware about the scores. The next round is about planning the workup, and we'll go from the reverse. So this question for Dr. Kedarnath will go directly to Dr. Ananya. So this is the first question, extra question for Dr. Ananya from the first scenario. So we have a day 14 child with atypical genitalia. On examination, there is no gonads. Uterus is present. Sodium is 138, potassium is 4.8, 17 OHP is 2. And the workup which was done subsequently showed that there was a 46XX karyotype. Now, this diagnosis was established even before we did any workup. We just asked one question and we were able to make the diagnosis. So what do you think is the likely diagnosis, and which clinical clue made us reach the diagnosis? So a 14-day child with atypical genitalia, no gonads, uterus being present, normal electrolytes and 17 OHP, and karyotype which is XX. Which clinical clue will make Dr. Ananya, this is a direct question.
Pass.
Okay, Dr. Vishal.
The AMH or inhibin B?
Sir, is there a history of maternal intake of any hormone or drugs?
Maternal intake of hormone or drug. That was not because Dr. Sania.
So whether hypertension is present or not.
Dr. Singh would like to give an answer. So this is the case of XX-DSD. You do not prefer hydroxyl deficiency. The simple question which we asked the mother was whether there was maternal virilization during pregnancy, and it was positive, and this turned out to be finally hereditary deficiency. The second important description of XDA. Right?
Your voice is not heard. Hello?
Can you hear now?
Yes, sir.
Yes, sir.
Yeah. So I think the answer, the question was very clear. So this was a very question in which basically what we are looking at is a scenario wherein we have XX-DHT with CAH being ruled out. The next obvious scenario in this regard is whether we are having a problem in terms of aromatase deficiency, and this was highlighted by the fact that we have got maternal virilization. So I think this was what we're looking at. Maternal drug history is extremely rare because usually those androgens will be destroyed by the placenta. And the other thing about 11-hydroxylase deficiency, usually they will have unlikely to have hypertension at this point of time. Hypertension happens a bit later. It is usually salt wasting because their mineralocorticoids are not good enough to really cause hypertension at this point of time. So I think that's what we're looking at. Next question is a direct question to Dr. Ananya. No, Dr. Ananya, because there is a second, no? Because there is a second scenario there. So we are going, no, this is for whom? Dr. Ananya, no? Because she got an extra bonus. Yeah. So this is again for Dr. Ananya. This is for you. Please concentrate. So 10-year-old boy with meningitis, sodium is 124, child is euvolemic, urinary sodium is 100, FT4 is 12.5 and cortisol is 550. A simple test which can discriminate the two most likely etiology in this setting. Dr. Ananya. So 10-year-old boy with meningitis, with hyponatremia, which is euvolemic, with high urinary sodium, normal thyroid, normal cortisol, two common differentials, and how do you differentiate them?
Water deprivation test.
Water deprivation test. The child already has got hyponatremia. So I think this is a different group that you're looking at. Dr. Vishal?
ACTH, sorry, vasopressin suppression test, sir.
Vasopressin suppression test by giving more saline. So what are you thinking of?
So to rule out the SIDH.
Okay, so this looks like SIADH versus. You're correct. SIADH is the possibility, but the other possibility. So we'll take other answers and go from there if it becomes easier. Dr. Anupama?
Pass.
Dr. Sania?
So we have to differentiate between SIADH and cerebral salt wasting. So we will go for the serum uric acid and the serum osmolality and urine osmolality. Urinary sodium levels also we will see here.
So one test if you want, single test?
Uric acid.
Uric acid. So this is clearly a case of Dr. Vishal was going in the right direction, but what we're talking about a very simple test. So we're talking about either a case of SIADH or salt wasting. SIADH is a hypervolemic state actually, and salt wasting is a hypovolemic state. So uric acid will give you the correct diagnosis. So this is SIADH versus cerebral salt wasting. You can do uric acid or fractional excretion of urate. That will be the best test. The AVP suppression test is not something which we do in routine clinical practice. If at all, some people use copeptin as a marker in that regard. So that will be less likely, but definitely very good answer, Dr. Sania. So we'll give 5 marks for pass for Dr. Sania. Now we have got a direct question, which is for Dr. Vishal. 6-year-old boy with early puberty, testicular volume is 1 ml, but has got pubic hair stage 4. Height is advanced, weight is reasonable, LH is low, and testosterone is extremely high. Now, simple biochemistry gave you a clinical diagnosis in this boy with precocious puberty. I just don't go in a fancy thing, simple test that can be done in any lab. Come within a couple of hours, you will get the answer.
Sir, voice is cracking, sir.
Can you hear now clearly? Dr. Vishal? Others are able to listen to me? Are others able to listen to me clearly? Dr.
Yes,
Rashmi?
sir.
Yeah.
Yes, sir.
Sir, voice is cracking.
Maybe you can hear now. You're seeing the scenario. A boy with,
Yes, sir. Yes.
with early puberty and LH is low, testo is very high, and a simple test gave us a clue. Testicular volume was 1 ml. What do you think is the most likely diagnosis that can be picked up here with a simple test?
Only biochemistry, sir.
Simple biochemistry. Yeah.
TSH.
TSH will not cause this level of precocious puberty. We'll go to Dr. Anupama.
It is likely a peripheral precocious puberty, CS.
Mm-hmm.
And we said
Yeah.
17 OSP.
17 OHP, but we're talking about a bedside test, simple bed test. No, not a bedside test, a simple biochemistry, not even 17 OHP. Dr. Sanya?
Is it inhibin B?
No, no. Dr. Rashmi? You can actually do the test in the, not even in the lab. There are some other equipments which are there, you can do it.
Is it our capillary blood glucose?
No, no. Dr. Ananya?
FSH.
Okay. So I think we are very clear that we are talking about somebody who has got a peripheral precocious puberty. So in peripheral precocious puberty, if you look at potassium levels and the potassium is low, what does it mean? 11 hydroxylase deficiency. So that is something which you can pick up easily. You don't need to send a sample for inhibin B or anything else. Even before 17 OHP, look at hypertension and hypokalemia. That will give you a picture. So I think that was a different one. So we'll carry forward on that. So this was hypokalemia. Now there is a direct question to Dr. Anupama. A 14-year-old girl with polyuria. She is having a height of 156, weight of 72. Blood sugar is 320, HbA1c is 9.5%. So clearly diabetes. There is acanthosis nigricans in the child. There is family history of diabetes. C-peptide levels are low. Ketone is negative. What would be your next test?
Antibody test, GAD65 or
GAD65. So you're looking at what is the most likely diagnosis here?
sorry, if type 1 GAD65 would be positive.
Yeah. So we are talking about a obese individual with non-ketotic hyperglycemia. So again, type 2 versus type 1. So before doing anything else, we should clearly go ahead and do a GAD antibody. So correct answer there. We'll give 10 marks to Dr. Anupama. Next question is a 4-week-old boy with failure to thrive. This is basically for Dr. Sania. Shock, sodium is 120, potassium is 6.6, creatinine is 0.4, 17 OHP is 6, genitalia is normal. So what would be your next test? So think about, this is all about planning of tests that we're talking about here. 4-week-old boy with shock, salt wasting crisis with a normal creatinine and a normal 17 OHP. Genitalia is also normal.
Cortisol test.
Cortisol test. Okay. Cortisol, we'll consider cortisol. Anything else which will give you a diagnosis like
ACTH after that.
cortisol and ACTH. We'll go for if we can get a very specific answer. Otherwise, we'll come back to you. Dr. Rashmi. So a male neonate with salt wasting.
Yes,
That
sir.
is the scenario. Maybe we'll go to Ananya then. Okay, we'll go to Dr. Vishal.
Pass, sir.
Dr. Anupama,
Radiological USC
to
abdomen
look for.
for Mullerian structures or
Uterine structures. Okay, the genitalia is normal, so you want to say that this could be a XXCH, but then the 17 OHP is normal. So I think what I was looking at, actually, I was looking at imaging to look for adrenal size. So if you look at the algorithm, hyponatremia with hyperkalemia in a male who is normal looking male, first thing is 21 hydroxylase deficiency. Second is adrenal hypoplasia congenita. That will give you a clue. But I agree that cortisol and ACTH will also give you a clue. So we'll give you the answer to Dr. Sania because that will fit into that perspective. Although for this, my mindset was more towards adrenal imaging, but this is also an appropriate answer to go for cortisol and ACTH. So we'll give 10 marks to Dr. Sania. So this was adrenal hypoplasia congenita. Next case is for Dr. Rashmi, 14-day-old boy with on neonatal screening, TSH is 142, FT4 is 2, thyroid scan shows no thyroid tissue. What will be your next test? So neonate.
So radionuclide scan to look for an ectopic thyroid.
Scan shows no thyroid tissues. Thyroid scan has been done. No, this is a radionuclide only.
Okay.
So what will be the next step? So
So
congenital
we do a trap.
trap. Okay, anything before trap? So we will go to Dr. Ananya. So scan shows no tissue. Next thing, trap or something else.
Pass, pass.
Dr. Vishal,
Thyroglobulin levels.
thyroglobulin levels. Anything simpler than thyroglobulin levels? You are in the same direction, but something which is easily to do. Dr. Anupama, Dr. Sania,
The USG thyroid.
USG thyroid. For what?
Sir, to look for the thyroid tissue.
So
As it is,
scan doesn't
TSH
show
is
any
one.
thyroid. Do you think still there could be a thyroid tissue? So you are correct. This is the apparent
Ectopic.
athyrosis. So if there is a, Dr. Ashmi was partially correct, but trap should come later on in the algorithm. So if there is an absent thyroid on scan, but your ultrasound shows a thyroid, this is apparent athyrosis, either sodium iodine importer defect, or you have a TSH receptor problem, or you have a TRAB antibody. So then you have to start thinking of. So again, I think 3 cheers to Dr. Sania for getting this right again. So now I'll request Ria to come up with the scores, please. In total, after 2 rounds.
Okay. So Dr. Rashmi has scored 10 after round 1 and round 2. Dr. Sanya has scored 30. Dr. Anupama has scored 20. Dr. Vishal and Dr. Ananya have not scored yet.
Okay. So don't worry, this is just the second round. There are 2 more rounds to go, and then buzzer round can really change the whole scenario. So we'll think of it in that regard. So this was an ultrasound thyroid. So now audience get ready for the chat option, and Dr. Kirti and Dr. Ria also get ready for that question. So a 4-week-old boy with seizures, ionic calcium is 1.9, phosphate is 7.1, creatinine is normal, PTH is 240. What would be the next test to do? So hypocalcemia, hyperphosphatemia, normal creatinine, hyperparathyroidism. What is the next test to do? Anybody has answered? Has anybody answered in the chat? Okay, genetic testing. Anybody else? Gene study, gene study. I think everybody is talking about gene study. Something very simple. Dr. Adel is talking about secondary hypocalcemia seizures. This is hypocalcemia with hyperphosphatemia, normal creatinine, high PTH. We always say this is pseudo-hypoparathyroidism, but before you label somebody as pseudo-hypoparathyroidism, you should get a vitamin D level done, because this could be a secondary PTH resistance. So I think, unfortunately, we'll not give answer to anybody. So this is what we were expecting, was to have vitamin D, because in this algorithm, if your vitamin D is low, you will have secondary PTH resistance. So we discussed about the scores already, which have been given in that. So we'll now move forward to the next round about treatment. So we spotted the diagnosis, planned the test, and then now we are planning the treatment. And this will go, I think, reverse from Dr. Rashmi. It will go forward from that regards. So Dr. Rashmi, we have a 12-year-old girl with altered sensorium. There has been a long-standing lethargy and weakness. Her sodium is 112. She has got cortisol and ACTH was on the lower side. So there was a hypocortisolism, was given hydrocortisone and 3% saline. Now, after 14 hours, you see that the sodium has gone to 122 from 112. What would be your plan here?
Continue 3% saline.
Okay, continue 3% saline, and the sodium 122, you want to continue the same rate and continue with the same treatment. Okay, we'll
Same
move.
rate and yes, sir.
Okay, so next would be to Ananya. What we would like to do something else?
Continue 3% saline.
Okay, continue 3% saline. Dr. Vishal?
Sir, continue same.
Same. Dr. Anupama?
It's already 10 millimole corrected in 14 hours. So I will slow the sodium correction.
You'll slow the correction, or you'll do something else as well?
Stop 3% NaCl.
Okay, Dr. Sania?
Whereas there is a rapid rise of sodium of 10 millimole in the 14 hours, so we will stop the 3% saline and give the water to decrease the sodium level, as it is not appropriate to increase the 10 millimole in the 10 hours.
I think that's a
In the
very, very
14.
good point. And so, yeah, absolutely right. So what we were pointing out here, this is a chronic hyponatremia, and you are correcting it very rapidly. There's a long-standing lethargy. You already corrected by 10 and 14, which means we're talking about 15, 16 in a 24-hour period. So in this case is a case for relowering. So you should relower the sodium level. And for relowering, you can use either 5% dextrose, free water, or desmopressin as well. So I think absolutely correct answer. We'll give 5 marks to Dr. Sania for pass. The next question is again to Dr. Sania. 7-year-old girl with precocious puberty. She has breast stage 2, pubic hair stage 1, no periods, height is 124 centimeters, LH is 0.3, FSH is 2.4, estradiol is 20. Ultrasound shows an endometrial thickness of 2.2 mm and a bone age of 8 years. So this mother is coming to you with all these child. This child is having early development. You ordered the test. Now, what is your plan at this point of time? So look into all the data, and then you can decide on that.
So we can reassure mother for 6 months, and after that we will reevaluate.
So what are you thinking here? What type of precocious puberty is this?
So it is the peripheral precocious puberty, as the menarche has not occurred, pubarch and the thelarche has occurred, only isolated thelarche and isolated pubarch.
So this is what you're looking at, is a isolated thelarche, you can say, or you can say slowly progressive precocious puberty, because the bone age is only 1 year advanced. The endometrial thickness is less than 3 mm. So this is classically 6 to 8 years. There is no need for treatment. So this is what I was looking at. So 6 to 8 year, there is no progressive puberty. Then you follow up for 6 months. So exactly you've given the right answer. So we'll give 10 marks to Dr. Sania again at this point of time. Next direct question is to Dr. Anupama. 2-month-old boy with failure to thrive and polyuria. Blood pressure is 60/40. Child is a bit dehydrated. There is alkalosis, pH of 7.56 and bicarb of 33. Sodium is 134. Potassium is 1.4. There is urinary calcium to creatinine ratio of 1 milligram per milligram, and magnesium level is normal. So first of all, think what the diagnosis is, and then consider what could be a good treatment for this case.
Sir, is it nephrogenic? Nephrogenic?
Think about it. Look at the whole case first. I think this is too much information there, so you have to think first, and then you will get the answer. I think it's not a difficult one. You're thinking of nephrogenic?
DI.
DI. Okay. So we'll move to from Dr. Anupama to Dr. Vishal.
Sir, Bartter syndrome.
Yes. And treatment?
Thiazide diuretics.
Okay. So endomethacin diuretic will give you the correct answer. So this is actually hypokalemia, alkalosis, normal blood pressure, hypercalciuria, normal magnesium. So this is a classical NAK2-CC problem, the furosemide excess sort of a scenario, you can say. This is Bartter syndrome. I'll take thiazide as well as an option in that perspective. Next case is directly to Dr. Vishal. 2-month-old boy with seizures, failure to thrive, and seizures and failure to thrive and polyuria. Calcium is 4.4, phosphate is 6.2, PTH was high, vitamin D was low. So just like the previous case we talked about, where we said in the audience round that you should get a vitamin D LAN, was managed with intravenous calcium, and now you are discharging the child. So what treatment will you advise at discharge to this child?
Sir, oral calcium.
And anything else?
And vitamin D.
Which vitamin D? So cholecalciferol. Yeah.
Cholecalciferol, sir.
Okay. Anybody has another answer, Dr. Ananya?
Pass.
Dr. Rashmi? So severe vitamin D deficiency with hypocalcemia. You've corrected the acute part. Now you will discharge on oral calcium, obviously with.
So we have to give a mega dose of vitamin D.
Okay. Anything else you would like to give?
Intramuscular.
Sir, Roquetrol.
We have to continue on calcium, sir.
Okay, so
High
Dr.
dose
Vishal-
calcium, 50 to 100
Dr.
milligrams.
Vishal has talked about out of the turn, but I think he was okay in the first one. So actually what I was looking at, because unless and until you give them calcitriol, they are not going to respond, because by the time your vitamin D works, even if you give a very high dose, they're not going to respond. So we'll give to Dr. Vishal.
Yes.
You have to give it both calcitriol, calcium, and vitamin D. Crux is calcitriol, because often we see patients, they come back to us and they really come back with hypocalcemia. So this is something important. So we'll go to the next question is to Dr. Ananya. 11-month-old boy with DKA, pH is 6.9, bicarb is 8, carbon dioxide is 10, blood sugar is 540, potassium is 3.1. I want you to tell me three things. So last question also had calcium, vitamin D, and rocatrol. Here also we are looking at basically what is your bolus fluid, what is your hydration fluid, and how much insulin dose will you give?
So bolus fluid, I'll give 20 ml per kg normal saline for 1 to 2 hours.
Anything in that, or only normal saline?
Potassium also will add based on the
No,
same.
look at these figures that we are given you. So for this case, will you add potassium, and if that, how much?
3.1, 3.5. I'll add 10 milliequivalents potassium.
So you will add potassium. Okay. What about the correction hydration fluid?
Hydration.
After you're given the bolus, the next
Bolus.
fluid you will give as? Just tell me the sodium and potassium as to, will you add normal saline you will give, N/2 you will give?
Normal saline only I'll give, sir.
With potassium or without potassium?
Initially, I'll give it without potassium.
An insulin dose?
0.05 international units per kg body weight.
I think we'll give you 5 marks there, because what I was looking at, you were correct in the first thing that you will give normal saline with KCl. But of course, in hydration, you have to give KCl because that is everybody you will give. And this child is hypokalemic to begin with. And insulin is correct. So I think we'll give you 5 marks for that part. Now we will have the extra question. And I think this extra question will go to Dr. Who should it go to? We'll give to Dr. Vishal this extra question. 3-year-old boy with 21 hydroxylase deficiency on hydrocort 25 milligram per meter square per day, fludrocortisone of 0.05, and yet the 17 OHP is very high. Now, which test would help improve your management or decide about the dosing?
Sir, electrolytes.
Electrolytes are normal. Anything which will give you a better clue. More sensitive than electrolytes. And what are you thinking of? Electrolytes will tell you at what you're expecting what. So what's going wrong in this case?
Cortisol levels.
Cortisol levels. No, we'll go now to Dr. Anupama.
So renin, serum
Renin
renin.
levels. Why are you
And
want to do the
aldosterone.
renin levels?
So we can adjust the dose of the hydrocortisone and fludrocortisone, sir.
So here the fludrocort dose is low,
Yes.
and when your fludrocort dose is low, you become hypovolemic, and when you become hypovolemic, your AVP level go up. They will cause more hydrocort requirement. So the problem here is the fludrocortisone dose. So I think that's the right answer. We want a plasma renin or a renin activity. So 5 marks to Dr. Anupama. So while we are collating these questions, after round 3, we will now go for the audience question. So again, audience, be ready for this one. I think a 14-year-old boy with obesity with developmental delay. Along with that, there is hyperphagia, infantile hypotonia. I don't think there is any doubt with regards to what we're looking at. But the question is, what treatment will improve body composition? So I'm looking at specific answer for what treatment will improve body composition. So Dr. Aisha has again talked about Beckwith-Wiedemann syndrome, growth hormone. Dr. Palani is talking about growth hormones. So Dr. Palani, because Aisha has already won one round, so I think we'll give it to Dr. Palani about Prader-Willi and growth hormone. I'll now request Kirti to talk about the scores.
Thank you, sir. So after the end of round 3, we have Dr. Ananya at 5 points, Dr. Rashmi at 10 points, Dr. Vishal at 15 points, Dr. Anupama at 25 points, and Dr. Sania is currently in the lead with 45 points.
Good. So I think we are heading forward to our next round, which will be the 4th round. And the 4th round will be spotting the diagnosis, and there will be no pass which is there from that perspective. So you have to make the diagnosis, you will get marks. If you don't make the diagnosis, it will not pass because it will become very easy. So we have to start, I think this is the 4th round, we'll start with Dr. Ananya. 10-year-old boy with seizures, calcium of 4.1, phosphate of 8.4. You see the clinical findings carefully. The CT is there, the X-ray is there, the leg examination. Now the question is, which parent most likely would have been affected in this case? So this is a textbook picture, probably you can think of. The diagnosis should be easy. The question is slightly evolved. So Dr. Ananya would like to make a guess. So what is the diagnosis you're thinking of? Okay, Dr. Vishal.
Sir, cutaneous calcification, brachymetacarpia, pseudohypoparathyroidism.
Yes. So which parent do you think that the disorder is coming from? Father or mother?
Sir,
Achha,
not
there is no
sure.
pass in this one, I think. So I think we'll not give a pass for that. So we can ask the audience.
Mother, sir.
So it is coming from the mother. So there will be no pass in this one, but this is coming from the mother. This is imprinting disorder, basically. Okay. So next question, direct question is, so we have to give another bonus question. So who is left with a bonus question? I think two people might be left. Dr. Sainia and Dr. And what are their scores? So we'll probably give it to Dr. Anupama as a chance. Okay. 5-year-old boy with early puberty, SPL is 8, testicular volume is 6, CT is normal, 17 OHP is 2, HCG is 10. What is the diagnosis?
It is definitely peripheral precocious puberty.
No, I want the specific diagnosis.
Adrenal tumor.
Adrenal tumor. Okay. CT adrenal is normal. So we've already given. So we have given excluded everything. So this is not CAH because 17 OHP is normal. CT is normal. HCG tumor is out. So this is a case of LHCG receptor defect or testotoxicosis. So this was the direct question from that perspective. The next question will, I think, go to Dr. Vishal. So this was the diagnosis. What we are seeing, the LH is low, adrenal is negative, 17 OHP is normal, HCG is normal, so most likely LHCG receptor defect. 6-year-old boy with hypoglycemia and pigmentation. Sodium is 129, potassium is 3.6, ketone is positive 2.4, cortisol is 220 nanomoles per liter during hypoglycemia. ACTH is very high. The child also gives a history of feeding difficulty. So, Dr. Vishal, what will be the most important examination to look at?
CNS examination, sir.
Thinking of?
Adrenoleukodystrophy.
Okay, so this is slightly, if you give, there are clues there. So this case is predominantly glucocorticoid deficiency. Potassium is not affected. There is hypoglycemia. Feeding difficulty is giving a clue towards achalasia cardia. So what we are thinking of here is something like a triple A syndrome where eye examination will give you a clue. ALD will be slightly different. Now, next is going to Dr. Anupama. I think this is her direct question. 12-year-old girl with high sugars on routine checkup, HbA1c of 10%, on insulin developed recurrent hypoglycemia. GAD is negative. Somebody got an ultrasound and this is what they found. What is the most likely genetic defect? So this is the ultrasound of the kidneys and it is showing something unusual. So Dr. Anupama, what are you thinking of?
I'm not sure, sir.
So there will be no mark, but anybody else is thinking of something. So this is diabetes which is gram-negative with renal cysts. So this is a classical case of MODY 5. This case is directly to Sania, 11-year-old boy with refractory rickets. You can see that there is a lower limb abnormality. The X-ray showing rickets, phosphate is 1.8. There is no metabolic acidosis. Calcium is 9.4. PTH is normal. You want to start treatment. Now, before you start treatment, you have to do a specific test. Very, very important test before you do the treatment.
ALP levels.
ALP levels. How will that help you?
Hypophosphatemia.
So this is hypophosphatasia will be very unusual in this. This is hypophosphatemic rickets. Very, very clear. I think everybody agrees with that. Late onset, lower limb, low phosphate, normal blood gas, normal calcium and PTH. What you should do is urinary calcium. If there is hypercalciuria, do not give them calcitriol. It could be a NPT variant. So this is important. So final question, which is there in this round, is a 8-year-old girl with short stature. This is for Dr. Rashmi. There is clinodectaly as well. You can see the abnormal facies. The question is short stature. What is the most common cardiac defect in this condition?
Coarctation of aorta.
Coarctation of aorta, and you're thinking this as Turner.
Turner's.
Something which is similar to Turner. Actually, this is Noonan syndrome.
Turner's.
So this
Known
is
as sir, pulmonary stenosis.
pulmonary stenosis, but I think we will leave that. So pulmonary stenosis, this is actually classically Noonan rather than Turner. So this was a bit confusing. Deliberately we gave that. So this is pulmonary stenosis, which is there. So while we collate all the answers, we have another audience question. And so 3-month-old boy with micropenis, inguinal hernia, there is hyponatremia and hyperkalemia. Head circumference is 32. Diagnosis established by a simple biochemical test. Again, so we are focusing on a simple biochemical test in that regard. So anybody in the audience has to answer the question. So pulmonary stenosis from the last one. Cholesterol Smith-Lemeli-Opitz syndrome, Dr. Bifina has given the correct answer. So this is what we are looking at. So now I'll request Dr. Ria to come up with the scores at the end of round 4, and this becomes very important.
So after round 4, nobody has scored in this round. So I'll be telling the scores total. Dr. Rashmi has scored 10 marks. Dr. Sania has scored 45 marks. Dr. Anupama 25 marks. Dr. Vishal 15, and Dr. Ananya has scored 5 marks.
What is the score in this case? No? Yeah, so total exact score?
Yes, sir.
Yeah, so just tell me.
10, 45, 25, 15, and 5.
So we have got, I think, people who are, the difference is 40 points. So if suppose somebody is able to answer all the answer in the buzzer round, they may actually pass. So anybody can win this particular scenario. So next will be the buzzer round, and we will explain the rule of the buzzer round. We don't have any question. So this is the fastest finger first. So what this is a buzzer round. Now think here carefully basically. So chat. So all of you are seeing the chat, I think. Can you see the chat?
Yes, sir.
So what we want is that when you have the chat, I will be writing N like this. And after that, once you are listening to the question, any point of time, you can say Y. So that will be your buzzer. So you just have to be writing Y. As soon as you write Y, we will stop the question there. And you have to immediately answer the question. You get the point? If suppose Dr. Anupama said Y, she has to answer the question. There is no pass, of course. There will be +5 for correct and -5 for the wrong answer. So first of all, we'll see if everybody's keys are working. So maybe you can put Y, all of you. So Dr. Ananya, we have got Dr. Vishal, we have got. Dr. Rashmi, Dr. Sania, you have not answered. Dr. Sania and Dr. Anupama,
Yeah, already,
you've
sir.
put?
Yeah.
We haven't got your answer, Dr. Anupama, in the chat, webinar chat. Yeah, we have got now. So now what I'll do, I'll put a N. Now, after this, this is the reset. So as soon as we get the answer, we will know the new person has written. So do not put it unless and until you are sure. But be ready with your Y. As soon as you think that you've got the answer, you can stop at that point of time. So there are 6 questions and +5, -5. So you can gain 30 points. So it can be absolutely open. And if somebody gets 6 minus, they will get -30 as well. So let's start with the first question. 16-year-old girl with irritability, FT4 is 34, TSH is less than 0.01. You find that there is a solitary nodule. Most appropriate treatment after stabilization of the patient. Girl with toxic nodule. So don't be too conservative. Dr. Anupama is there. Yeah, Dr. Anupama, what's your answer?
Surgery, sir, since it is toxic solitary nodule.
So you will go for surgery. Yeah?
Yes, sir, after
Okay. So that's the correct answer. We'll give you 5 points on that. So +5 to Dr. Anupama. Next question. Again, open for other. Just 1 second. So now you can answer. 3-year-old boy with polyuria, dehydration, urinary osmolality is 50, sodium is 156. What should be your next test? You don't need to wait if you want. So Dr. Anupama is again there.
Vasopressin test, sir.
Vasopressin response test. So this is already proven to be a case of diabetes insipidus. We just have to confirm it. So we'll do a vasopressin infusion test in that regard. So I'll again reset the scenario. Now the next question again on buzzer is 12-year-old girl with multiple fractures. You can see the x-rays. There is failure to thrive, polyuria and myopathy, hypokalemia, phosphate of 2.1. There is acidosis, urinary pH is high, nephrocalcinosis is there. Other than bicarbonate and potassium, what else will you give this child? Dr. Vishal?
Thiazide diuretic, sir.
Thiazide diuretic, absolutely right. So 5 points to Dr. Vishal. This is distal RTA and thiazide diuretic is something which is required from that perspective. So I'll reset the thing again. So thiazide is recommended. Next question, the fourth one is 1-month-old girl with lethargy, hyponatremia, hyperkalemia, normal genital appearance. Cortisol is 650, 17 OHP is normal, renin is high, aldosterone is high. What will be your next step to achieve the diagnosis? So 1-month-old girl with hyponatremia, hyperkalemia, normal genital appearance, normal cortisol. Dr. Vishal has again come up. Dr. Vishal, your answer?
Karyotyping, sir.
Karyotyping is the wrong answer. So this is a girl with normal genital appearance, meaning there is no testes as well. So what we are looking here is pseudo-hypoaldosteronism, and we should go for renal ultrasound. So we'll deduct 5 marks from there. So after 4 questions, what is the status? So we have got 2 more questions left, and Dr. Sania is at 45. Dr. Anupama is at 25. Dr. Vishal is at, no, Dr. Anupama is at 35. So there is a difference of only 10 marks between Dr. Sania and Dr. Anupama. Dr. Vishal is at 15. So I think the top 2 positions can change from here. So there are 2 more questions there. So I think it's all for those 2 to go forward and see what they can do from that regards. So the next question, again, I'll reset it. Now be ready. The next question is severe decay on decay protocol has leg pain, high colored urine, oliguria. What could have prevented this complication? So this child was being managed as very severe decay, pH of 6.8. Now suddenly there is a leg pain, there is hematuria, oliguria. So something was wrong in the management that caused this. Anybody? So Dr. Rashmi?
Sir, hypokalemia must have been prevented. Rhabdomyolysis.
Rhabdomyolysis. So hypokalemia or something else?
Is it thromboembolism, sir?
No, Dr. Rashmi is clear, so I won't deduct her marks, but I'll say hypophosphatemia. So we should have given potassium phosphate to begin with. This is rhabdomyolysis, but it should be the phosphate. So this is the correct. So it's both ways nullifying the answer. So I think we'll keep it at 0 from that. So now I think we have got the answers. Final question, which is there. So this is the 30th question. And we have got 45 for Sania, 35 for Dr. Anupama, 15 for Dr. Vishal, Dr. Rashmi is that 10 and Dr. 5. So I think we have got the I think winners are pretty much clarified, but we should have this last question. Okay, so we'll put the N there. And now 15-day-old girl with hypoglycemia, birth weight was 3,200 grams, GIR is 14, ketone is 1.1, insulin is 3.2. Now, which biochemical test that will establish the diagnosis of hypoglycemia? Dr. Vishal?
Sir, potassium.
Potassium. Okay, so we'll give you the clue here, but I think the answer that we are looking at was ammonia, but potassium can also give you a clue about that, but that's okay. So we'll give you 5 marks there as well. So with that, I think we are coming to the end and we have the audience question coming up again. So we will request audience to answer this question. 13-year-old girl with backache. You can see the MRI picture, the eyes. What is the most appropriate treatment? So anybody from the audience is talking about treatment now? Bisphosphonate, again coming from Dr. Palani Raman. Dr. Khalid is talking about alendronate. So I think we'll give it to Dr. Khalid because Dr. Palani Raman already had won one of the rounds. So I think this is a case of OI type 1 and this will respond to bisphosphonate in that perspective. So the final scores. We've got the final scores with Dr. Sania is at 45. So she has won. I think we will give a round of applause to Dr. Sania. Second position is to Dr. Anupama with 35. So that is the scenario to go forward. Before we start with the second quiz, we will quickly have a feedback from all of you. Dr. Sania.
Hello, sir. So it was a wonderful quiz. We had learned a lot in this.
So hope it was not very difficult.
No, sir.
Dr. Anupama.
Sir, it was a wonderful experience and I got to know where I stand and I have a lot to learn.
No, so quiz is of course meant to be hard. So it's not that in real life you will always get time to answer and you can always think about it. It's mainly to provocate your mind and go from there. Dr. Vishal?
Sir, excellent quiz. A long time after post-graduation, I attended the quiz and enjoyed a lot, sir.
Thank you. Dr. Rashmi?
Yes, I enjoyed the quiz even though I didn't do it well. Actually needed preparation, sir, which I had not done. So, but anyway, I enjoyed it.
Okay. And Dr. Ananya?
It was a very informative quiz, sir.
Okay. So I think I'll thank all the participants of the basic round. And we will now be moving for the advanced quiz. We have got Dr. Shyam Sundar who is there, Dr. Salik who is there, Dr. Mohit who is there. Who else is not there? Dr. Vignesh, Dr. Varsha, and one more person, 6 more things. So can you connect with them? So before we start off with the advanced quiz and we'll wait for the other people to join in, I'll like to introduce the people who are joining in from there. We've got Dr. Shyam Sundar from CMC Vellore. Dr. Shyam, can you introduce yourself?
One second.
Yeah.
Right. Hello, I'm Dr. Shyam Sundar. I'm a fellow from in pediatric endocrinology from CMC Vellore.
Okay, and that's good. We have got Dr. Salik from AIMS Bhopal.
Good afternoon, sir.
Yeah, please, so you introduce yourself. I think everybody knows you. You have been part of the quiz. I think this is your second quiz.
Yes, sir.
Yes.
Okay, I'm Dr. Mohammed Salik. I'm currently doing second year DM pediatric resident in AIMS Bhopal.
And we have got Dr. Mohit. Dr. Mohit, please introduce yourself.
Just a minute, sir. Hello, I'm Mohit Kumar. I am doing my DM from PGI Chandigarh, DM Pediatric Endo.
Okay, yeah. We have got Dr. Varsha, who is joining from Karachi. So, Dr. Varsha.
Hello, I'm Dr. Varsha, joining from Pakistan, Karachi. This is my second time.
Okay, great, Dr. Varsha. And I think you were taking exams today, I think.
Yes, I did.
Okay. Dr. Vignesh is there from Pondicherry.
Hello, sir.
Yeah, please introduce yourself.
Am I audible?
Yes, you are audible.
Yes, sir.
Yeah, you please introduce yourself once.
Yeah. Okay, yes, sure, sir. So I'm Vignesh. I'm doing a pediatric senior residency in JIPMERS currently.
Okay, so we have got 5 people who have joined. I think Dr. Mohsin is the only one who is not there. We'll start the quiz right away. If as and when he joins, we will see. Otherwise, we will have to redistribute his scenario from that perspective. So advanced quiz is basically more advanced, and you will realize that it is much more compared to the basic one. And hopefully it will be interesting and will shed new lights from that perspective. This is again going to be clinical. So we are going to talk about clinical cases, scenarios, but much more latest developments will be focused on. And I hope now the screen is visible to everybody. And we will again have a first prize will be the advanced course, which will be there. Along with that, we've got the second prize for the basic course. And then the finalists will already be awarded prizes from that regard. So we've got these 6 participants, Dr. Varsha, Dr. Mohsin from Jammu, Dr. Mohit Kumar from Chandigarh, Dr. Shyam Sundar from CMC Vellore, and Dr. Mohammed Salik and Dr. Vigneshwaram. So we'll have 4 rounds and it will go from 1 to 6 and 6 to 1 for these 4 rounds. And then we'll have the final buzzer round, just like the basic quiz we just had. So 4 direct and 1 buzzer round, 10 marks for direct, 5 for buzzer, 15 seconds to answer, only 1 answer. So be very careful when you're answering the question, and quiz master decision will be final. So we'll not have any other discussions on that. So again, similar sort of a round format. First question will be to Dr. Varsha. So this will be the first question starting from Dr. Varsha. Spot the diagnosis. 2-year-old girl with precocious puberty. She has stage 3 breast and pubic hair development. Her LH is 1.2, FSH is 2, estrogen is 30, MRI is normal. The family history is very significant. There are her brother and 2 cousins have precocious puberty. Now, think about the question. What I'm asking about is that there is this gene defect. One of the manifestations of the same gene defect is that you may have obesity syndrome because of the same gene. So you have to identify first the diagnosis. So it's a bit there, but if you think of it, it'll be easy. So what is the genetic defect? And this genetic defect is associated with one of the obesity syndromes. So this is a two-level question.
It is a central precocious puberty. Genetically, maybe if there is family history, the genes involved, MRKM3 could be one of the cause for this genetic precocious puberty. And sometimes it is also associated with obesity.
So which syndrome of obesity is associated with that gene? That is a very, very evolved question. You've got half the answer right, but I want you the full half. And maybe we'll go to other people and see what they are saying.
Monogenic obesity.
We will come back to it. We'll come back to you again. Dr. Mohsin, I think, has not joined, so I think we'll leave it there. Dr. Mohit?
Sir, related to DLK1, sir.
DLK1, but which obesity syndrome is associated with DLK1? So I think you are in the wrong track. Dr. Shyam Sundar?
It's MKRN3 and Prader-Willi syndrome.
Okay, so that is what I was looking at. So this is actually an evolved question, actually. So you got MKRN3, but it is actually what we're looking at was Prader-Willi syndrome. So I think, unfortunately, we'll give it to Dr. Shyam Sundar. 5 marks, we'll give it from there. So all these questions are a bit more evolved than the basic ones. So you have to think more here. Now this is, I think, to Dr. Mohit again, direct question to you. Most common endocrine manifestation of this disorder? So you have to first identify and then you have to tell us. So what do you think on the MRI? So Dr. Mohit, you like to give the answer for this one?
Sir, pass.
It's a direct question. Okay. Dr. Shyam?
Is it central precocious puberty?
In the setting of? What is the underlying condition?
Cyst, arachnoid cyst.
Arachnoid cyst. So this is a arachnoid cyst, a very, very specific scenario of CSF, which is getting collected in that perspective. So I'll just point out there. So there is a CSF collection which is causing pressure, and this pressure effect is causing precocious puberty. So will you treat this by surgical drainage?
It's not needed.
So only if there is a pressure effect. So again, correct marks to Dr. Shyam Sundar, 5 marks will give to Dr. Shyam Sundar. Next question is directed directly to, okay, so actually Dr. Mohsin is not there, no? He's not joining. So we'll again have to split his part to the other one. So we'll again have to give this to Dr. Shyam. This is your CT scan, and there is an endocrine condition which is associated with this finding. It may be the cause, it may be the effect. So you can think of it.
So this is calcification in the frontal region. So the endocrine associated is nephrogenic delay.
Okay, absolutely right. So I think you're doing very well. So I think all the 3 questions have been answered by Dr. Shyam Sundar. So good. So 10 marks, I think there. So it is the intracranial calcification, which is probably, what is the cause of this intracranial calcification?
I'm not sure.
So some people say it's dehydration, but it is because it doesn't happen in AVP deficiency. It only happens in AVP resistance. So it may be non-V2 receptor effects of vasopressin. So vasopressin is causing other effects causing calcification. Levels are very high. They're not acting on the V2 receptor, but they are acting here. So we'll move forward to the next question, which is to Dr. Salik. Dr. Salik, you're there?
Yes, sir.
Yeah. So this is a boy with short stature, your classical clinical features. I want you to tell the diagnosis and the gene which is implicated here.
Pycnodystrosis and cathepsin deficiency.
So cathepsin kinase and pycnodystrosis. So that's the correct answer. We'll give you 10 marks. Yeah. So I think that's very good. So these questions are going really fast. Everybody is answering those questions. Next case is to Dr. Vigneshwaram. 16-year-old girl on routine screening, FT4 is 34, TSH is very low. There is no clinical features of thyrotoxicosis, goiter, tachycardia, eye signs. Clinically, the child is euthyroid. TRAB is negative. Technetium scan shows a normal uptake. So what do you think is the cause of this findings?
This child is having hyperthyroidism, but however, there are no features suggest of hyperthyroidism.
Yes.
And it can be any lab related or some external source.
Okay, so what do you think is the most common cause which produces this biochemical picture?
So any
This is very
biotin,
yes.
biotin excess.
Biotin intake, biotin excess, definitely. Very good. So that is what we are looking at. So we'll give 10 marks to Dr. Vignesh. Now the last question we will go to Dr. Varsha because we'll have extra questions there. So 17-year-old girl with incidental thyroid nodule, small nodule, 0.8 into 0.6, non-palpable, clinically euthyroid. There is no cervical lymph node. TSH is normal. You find this on clinical examination. What is your likely diagnosis and which blood test will give you the diagnosis?
This picture of Cowden.
Cowden syndrome, no. We'll go forward to Dr. Mohit.
Sir,
Yeah.
Carney complex, sir.
Carney complex, no, it's different than Carney's. Carney's is more like lentiginous. You are seeing some, but there's a very specific finding. Dr. Shyam?
This is CL cutaneous lichen amyloidosis, and the diagnosis is MEN2A.
Okay, so absolutely right. We're talking about MEN2A. This is amyloidosis, itchy cutaneous lesions which are thickening of skin. So this is very typical, and you will get a calcitonin. I think we'll give a 5 marks in that. So we have had the first round. Before we had the tabulation of scores, we'll go for the audience question. 3-year-old boy with polyuria with low urinary osmolarity, serum sodium of 156. After desmopressin, it became urinary osmolarity was 150, which increased after giving desmopressin. Diagnosis was established by examination, by which findings? So I think this is what we are looking at in terms of the participants. What do you think they are going to be putting up in terms of diagnosis? So Dr. Palaniraman is saying histiocytosis. Aisha is saying histiocytosis. Dr. Namita is saying LCH with bony cystic lesion. So I think Dr. Namita is correct. We'll give it to Dr. Namita for this. So we will have Dr. Ria who will tabulate and tell us about the score after round 1.
Thank you, sir. That was a very interesting round. In the end of round 1, the maximum score has been achieved by Dr. Shyam Sundar with a score of 25. Dr. Vasha has and Dr. Mohit has not scored yet, and Dr. Salik and Dr. Vignesh with 10 each.
Okay. So very, very interesting round, but there's a lot of rounds left. So I think things may change very quickly. So we have got the next round on novel therapeutics and we will reverse. So it will start off with Vignesh. So the first question will go to Vignesh. 18-year-old girl with 21 hydroxylase deficiency. She is on hydrocortisone of 18 milligram per meter square per day. 17 OHP is sky high. Despite this dose, she is not responding to prednisolone, dexamethasone. Often happens in this age group. There is a novel non-glucocorticoid treatment which has been developed for CAH. I want you to mention that, which can be thought of in this case.
Is it crinecerfont and CRH receptor antagonist?
Okay, very good. So this is very good. We are looking at CRF receptor antagonist. So we will give full marks to Dr. Vignesh. The next question would be to Dr. Salik. 11-year-old boy with hypophosphatemic rickets on phosphorus of 60, calcitriol of 0.25 twice a day. You are planning to switch to burosumab. What is the most important step before you start that treatment?
Checking the urine calcium creatinine ratio.
No, this case is, so anyway, we'll go forward. So we'll discuss this again. So Dr. Shyam?
To stop calcitriol.
How many days before you start the treatment?
I'm not sure. I'll just guess. I think it's 7 days or 14 days. Not sure.
Absolutely right. 7 days. So you have to stop calcitriol 7 days prior to you give this treatment. So this is very important. Otherwise, you will cause severe problems in that perspective because it's going to stop your FGF23 and your calcitriol production will go up. You will have severe hypercalcemia. So 7 days before you stop that. So again, 5 marks to Dr. Shyam. The next question is again to Dr. Shyam. 12-year-old boy with type 1 diabetes, 8-year-old brother has got GAD positivity, ZNPT positive, sugars in the boy. The other sibling is slightly high, A1C 6.3. Which drug has been FDA approved in this scenario and what is the mechanism?
Is this to, am I audible? Yeah. This is to reduce the postprandial hyperglycemia.
No, overall in this condition, you can think of this is a child whose sibling has got antibody positivity, who has pre-diabetes. You can think of it that way. So a specific therapy has been approved.
Okay, this is teplizumab, CD3, anti-CD3 to prolong phase.
Yeah, so this is basically for stage 3 or stage 2 type 1 diabetes from the perspective. So it's teplizumab, again, full marks to Dr. Shyam Sundar in that perspective. 6-year-old boy with eruptive xanthoma, cholesterol is 550, LDL is 350, very high, no response to statin and ezetimibe. siRNA based therapy, which has been approved in adults, and the mechanism. So what I'm asking in a simple term is that there is a recently siRNA based therapy which has been approved in adults with severe hyperlipidemia. So Dr. Vignesh.
Is it
Dr.
Mohit?
Mohit, yeah, Dr. Mohit. Yeah, please go ahead.
Sir, inclisiran.
Absolutely right. So that is, and how does it work?
Sir, the silencing RNA against PCSK9.
Absolutely right. So it's a PCSK9 inhibitor, you can say, but this is a different mechanism by siRNA. So this is approved. Absolutely right. Full marks to Dr. Mohit. Dr. Mohsen is not there. So this question will go to Dr. Varsha. 14-year-old boy with pneumonia, drowsiness, sodium is 125, urinary sodium is 100, FT4 is 18, cortisol is 540. Recently, an anti-diabetic drug has been approved for treatment of this condition in adults. So I'm asking which anti-diabetic drug can be used. This is of course no diabetes, but it's being used in this condition. So first you should think of what the condition is, and then you can think of what can be the anti-diabetic drug.
SIADH.
Okay, so this is SIADH. The next question is which drug?
SGLT2 inhibitors, I'm not sure.
You are sure. So SGLT2 inhibitor is the right answer. Empagliflozin in particular, because they cause aquuresis. So you will lose free water there. So it's been found to increase sodium levels by 3 to 5. So not very effective, but slow rise. So absolutely right. So 10 marks to Dr. Varsha in that. So now we have an extra question. We'll give it to Dr. Vignesh. 12-year-old boy with polyuria, plasma glucose is 160, 2R is 250, HbA1c is 9. There is no response to metformin. And then somebody went somewhere internationally heard that there's a new drug called tirzepatide, which is approved of its use in the US and some part of the Europe. So the question is a bit tricky, but which trial led to its US FDA approval? It was in the news, so that's why I thought rather than going for tirzepatide. So what exactly is tirzepatide? Maybe you can tell us that first.
So tirzepatide is a dual drug. It's like a GLP-1 and GLP-1 antagonist.
Yes. So which trial? If you tell us the trial, we'll give you full 10. Otherwise, maybe we'll give you half. And if
I
others
know
don't
only,
tell us it.
I know only the today trial, but that is not this trial.
Yeah, today is much earlier. So today was yesterday. So now I think we'll go forward from Vignesh to Dr. Salik.
Is it surpass?
Full name?
That I don't remember, sir.
We'll look into it. Dr. Shyam Sundar.
Surpass speed.
Surpass speeds. So I think that's a very logical one. So it's surpass speeds actually is the right name. We'll give, I think, 5 marks to Vignesh because he got at least the GLP, GIP. This is more of a theoretical one, and maybe 2.5 for the surpass speeds. This is what we're looking at, both aspects. So we've done 2 rounds now. This is the audience question. Meanwhile, you can prepare the situations there. 14-year-old girl with polyuria, blood sugar is 450 with DKA, managed with insulin infusion. Now, which clinical finding predict transient form? So if somebody had attended and heard about it, they will know the answer. This is for the audience. So transient neonatal diabetes, which is the clinical finder. We showed a picture also, I think, in the basic quiz. Okay, ear crease, I think both of them are already given the answer, Dr. Ayesha and Dr. Namita, but they already won individual rounds. So ear crease, I think, and will be the one to go for Vignesh Prabhakaran, omphalocele umbilical hernia. So we'll include Dr. Vignesh from that. So I think we have got the second round, which is ended, and we'll take the scores now. Dr. Yes.
Thank you, sir. So we've been having quite a cutthroat quiz right now. We have Dr. Varsha at 10 points, Dr. Mohit at 10 points, and Dr. Salik at 10 points. Dr. Vignesh is at 25 points, and Dr. Shyam Sundar is at 42.5 points.
Okay, so we are having a very interesting one, but there are a lot of rounds left. So we'll go now to the third round, and we'll go start from Dr. Varsha again. So this is about diagnostic dilemma. 14.5-year-old boy with delayed puberty. There is a family history in father. Height is 148, weight is 45, testicular volume is 2 ml, pubic hair is stage 1. Now, this is a very specific question. I'll only take that answer. Which test has the best diagnostic accuracy to identify CDGP in this setting? And we want only one answer. There can be many, but which is the best diagnostic accuracy here?
Inhibin B.
We'll go further. We'll see other people what they are saying. Mohit, Dr. Mohit.
FHS stimulated inhibin B.
Yes, so I think PGI is doing a lot of FSH stimulated inhibin B, Dr. Rama. So I think that is what we are looking at actually, because inhibin B is not very good diagnostic accuracy alone. If you stimulate with FSH, you get the right answer. So that will be the one we are looking at. So 5 marks to Dr. Mohit. The next question will be for Dr. Mohit again. 12-year-old boy with polyuria, urinary osmolality is 120. Water deprivation test showed central DI. CSF, blood, HCG, and calcium were all normal, and you can see that there is something in the stock which is thickened. Now the question is, skeletal survey was also normal. So the big question is that test that makes germinoma diagnosis unlikely. This is to Dr. Mohit again, direct question. So you have got somebody with central DI who has got a normal CSF, blood, HCG, calcium, skeletal survey. There is stock thickening. Key differentials are germinoma versus, you know what? We want to know what is the test which makes germinoma unlikely. Any guesses?
Sir, on biopsy, we can see immunohistochemistry.
That will be the last step. So anything else we are looking at? So we'll go now to Dr. Shyam Sundar.
So the differential will be autoimmune hypophysitis. Raphelin 3A antibody can be done to differentiate both.
So this is what we're looking at. The best diagnostic accuracy is Rabifilin antibody, which will give you the clue. So again, 5 marks to Dr. Shyam Sundar. Next question is directly to Dr. Shyam Sundar. 14-year-old boy with short stature, height is 120, weight is 26 kilograms, coarse skin, testicular volume is 10 ml, pubic hair is 1, FT4 is 6, TSH is also 6, prolactin is 2. There may be some other explanation, but I want a very specific gene which can explain everything that I mentioned out here. Single gene can explain everything.
So there is short stature and central hypothyroidism.
Yes.
And prolactin is also low. So probably PIT1.
PIT1, but there is something else that is also there. So we'll move forward to Dr. Salik.
So is this a TRH receptor or something?
No. Dr. Vignesh.
Is it both PIT1 and prop? Because it's involving
Okay, PIT prop that you're talking about. Anything, you're missing on one specific finding which is there. I'll come back to that. Dr. Varsha.
Pow, pow, powerful.
POW1, no. We've already discussed in the same lines. Dr. Mohit?
Sir, IGSF1, sir.
Absolutely right. This is what I was looking at. So what you're looking at, if you look at PIT1, POW1, PIT1 usually will have prolactin and thyroid deficiency, but TV will also not be increased. Often you will have gonadotropin deficiency. They will be much more shorter. They'll be much more severe. So this is a very specific constellation of large testis with no pubic hair growth, central hypothyroidism, low prolactin. So this is IGFS1. So absolutely right, Dr. Mohit. We'll give you the pass marks here. The next question is a direct question to Dr. Salik. 4-week-old boy with salt wasting. Sodium is 116, potassium is 7, 17 OHP is 200, joint hypermobility is there, and there is skin laxity. So which gene defect is there, along with, of course, the obvious one is 21 hydroxylase deficiency? What is association of this causing this manifestation, Dr. Salik?
This is a continuous deletion of TNXB.
Okay, causing?
Ehlers-Danlos plus CH, so CHX syndrome.
Okay, very good. So this is the same, the TNXB, Tinaxin X, which is there, along with that is causing this problem. So I think 10 marks again to Dr. Salik. Now we have a direct question for Dr. Vigneshwaram. 6-year-old girl with Cushing syndrome. LDDST was showing 140. So low dose dexamethasone suppression cortisol was 140. Urinary free cortisol was high. ACTH was undetectable. The CT scan is on the right side. There was one dynamic test which clinched the diagnosis. So think about it and you'll get the diagnosis, I think.
So this is ACTH independent Cushing syndrome. So
Yes.
it's arising from adrenal.
Yeah.
So dynamic test to.
So unusual finding on the dynamic test made the diagnosis. Let's put it this way. So we'll go to Salik.
Sir, it is actually HDDST causing a paradoxical rise for PPNAD.
So it's a PPNAD wherein you have a paradoxical rise with the use of HDDST. This is what I was looking at. This is a very good answer. So now we have to give the extra question too. So we will give this to Dr. Mohit this time. Yeah. So Dr. Mohit, this is your direct question. 18-year-old girl with primary amenorrhea, breast stage 1, pubic hair 4, height is 176. There is facial acne, clitoromegaly. FSH is 41, LH is 26, estradiol is 60. What is the genetic basis and expected bone age in this case? So this is a direct question to Dr. Mohit. So what are you thinking of?
So, estrogen receptor mutation, sir.
Okay, which receptor?
So estrogen receptor beta.
Estrogen receptor alpha, ES1. Okay, I'll give you. But what is the expected bone age?
Bone age would be lesser because for fusion we
Would be
require
retarded.
estrogen.
Okay, absolutely right. So we are talking about ES1 defect. It will be delayed bone age. So this is the end of the round 3. Before we collate the score and Ria will come us and tell us about the score, we will have the audience question. 6-month-old child with failure to thrive, pigmentation, hepatomegaly, hyponatremia and hyperkalemia, and you are seeing this on X-ray. So simple routine test gave us the diagnosis. So we'll look into the Q&A. If somebody can tell us the answer for this one. So serum cortisol, no. So this obviously has hypocortisolism, but we're looking at hypocortisolism with abdominal calcification. So it looks like an adrenal calcification. So what are we thinking of? We are thinking of Wolman syndrome. And in this setting, you will have lipid profile, which will give you the answer. Dr. Namita has mentioned Wolman. She's already there, I think, in the group. So before we go ahead with the 4th round, we will have the score for the 3rd round.
After the end of round 3, the scores are Dr. Varsha has scored 10, Dr. Mohit has scored 30, Dr. Shamsundar has scored 47.5, Dr. Salik has scored 25, and Dr. Vignesh with 25.
So I think we are having a good competition. So we've got full round now, and then we've got a buzzer round as well, which is there. So next one is on endocrine diagnostics, and we will go reverse. We'll start with Vigneshwaram. The first question is 16-year-old girl with amenorrhea. FT4 is 0.4. TSH is 3.4. This is the first report. MRI was normal. Cortisol was normal. She was started on thyroxine. And at 4 weeks, you get the report TSH is 90. What do you think has happened? So what is the initial picture that you're thinking of?
So it's looking like central hypothyroidism. Sorry, yeah, it's central hypothyroidism.
But later on, the TSH is 90.
Later on,
So what
TSH is. So can it be some macro TSH or some lab?
So which lab issue? Of course, there's a lab issue. This is a diagnostic section. So here's a lab issue. I want to know which lab issue can cause this picture. Biotin we discussed last time. Somebody gave a good answer of biotin. What sort of picture can be caused by this?
Not sure, sir.
Okay, Dr. Salik?
Sir, is the report is immediate or later?
This is after treatment. So you have given 1 month treatment, and after 1 month, you thought that somebody got a TSH, it was 90. So it's a very, you don't expect TSH to go up. So this is the thing, yeah.
It's a macro TSH which can be done using a pegylation, which will be given a better answer.
So, but macro TSH, why would the FT4 be low to begin with? Yeah. Dr. Shyam Sundar? Yeah, we'll move forward here. Dr. Shyam?
Now, was it probably hook effect?
Hook effect in the first scenario. Okay. We will look
or
into that.
heterophile antibodies.
Yeah, I'll give heterophile will be a much more likely explanation for the first one. Hook effect will be not to this tune, I think. So I think we'll give you the pass mark for that, 5 marks. Next question is a direct one for Dr. Salik. 8-year-old boy with hypoparathyroidism, candidiasis and adrenal insufficiency, labeled as APS1 defect. 2-year-old brother who is asymptomatic, and the parents want to know whether this child will also develop APS1 or not. So which is the test with best diagnostic accuracy to predict this? And I'm talking about specific and sensitive, both.
Is it interferon?
Interferon?
Interferon antibodies against
interferon antibodies. Okay, I'll give you that. So this is So genetics can be very confusing in this scenario.
Yes,
So anti-interferon alpha and gamma antibodies is what we were looking at. So 10 marks to Dr. Salih. Next question is to Dr. Shyam. You are planning a research study on effect of environmental disruptors and stress level. And as part of your study, you want to assess chronic cortisol status of that individual, which is the new test which will give you an indicator about the chronic exposure to cortisol.
Something like 21 deoxycortisol.
No, long-term exposure. So we'll go to Dr. Mohit.
Pass.
Dr. Varsha.
Pass.
Okay. Dr. Vignesh.
Not sure, sir.
Who else is there? Dr. Salik?
No idea, sir.
Yeah, so this is there. So this is a very interesting concept of hair cortisol. And in fact, this is from a study which we looked at. Hair cortisol is now established measure for all these stress activities. If you want to look at the long-term exposure, hair cortisol is the way to look for. So this is why that I put this question there. Next one is to Dr. Mohit. 7-year-old boy with 21 hydroxylase deficiency diagnosed at birth. Hydrocort is at 16, fludrocort is at 0.1. Disease is uncontrolled, growth velocity is high, bone age is advanced, but 17 OHP is only 3. There are novel disease control markers which can really give you a better idea than 17 OHP of control. So we want to know which novel disease control markers have been approved for follow-up of CAH.
Uh, 21 deoxycortisol.
No, anybody else? Dr. Varsha?
Sir, backdoor pathways marker 11 oxygenated androgens.
11, okay. So they are not really the backdoor markers. Backdoor is a different pathway, but I'll give you the marks there. It's a very good answer there. So it's 11 oxygenated C19 androgens. They are actually now going to, hopefully by the next couple of years, they will become the best test for adrenal androgen production. DHEAS may also go off. So this is a new thing which is coming up from that perspective. So again, 5 marks for Dr. Varsha. That was a good answer. A difficult question. Now we have a direct question to Dr. Varsha again. 15-year-old girl with obesity. She has no Cushing-White feature. Her overnight suppression showed a cortisol after overnight test of 170. Urinary free cortisol is normal. What could be the reason? She's on some medications. What do you think could have caused this picture? Which medication could have caused this picture?
OCPs?
OCPs, okay. OCPs will cause higher level of overnight suppression and urinary free cortisol is normal. Okay, I'll give you anything else you can think of other than OCPs. OCPs can cause, so I'll give you the answer. That's right. Okay, so what I was looking at was a phenytoin or phenobarbital, which are going to inactivate dexamethasone. But absolutely right. If you are somebody on estrogen and you are measuring total cortisol, this will also give you a false scenario in that regard. So 10 marks there to Dr. Varsha. Now this is the last question and we have to give it to Dr. Salik. Dr. Salik, this is an 18-year-old girl with hirsutism and oligomenorrhea. High testosterone of 88, PCO appearance. You start on estrogen progesterone, but after 3 months, there is no clinical response. Now, you want to see whether there is a biochemical response or not. So, which will be a good test to look for biochemical response in quote-unquote PCOS or PMOS?
Sir, free testosterone.
And when will you do that?
That
Which part of the during the medication, after the medication you've stopped?
Before, like before the next dose.
Yeah, so I think once you've stopped, there's a gap phase, you will do that. So
Yeah.
pre-testosterone, we will give you the answer. So again, this will be the 10 marks there. So after round 4, we will have the scores from Kirti will come up and give us the score, and then we will start off with the buzzer round. Yeah.
So after the end of round 4, we have both Dr. Varsha and Dr. Vignesh at 25 points, Dr. Mohit at 30 points, Dr. Salik is at 45 points, and Dr. Shamsundar is at 52.5 points.
So it's now really tight now. Everybody is within the range, and we know there are 6 questions and we can get 30 marks. So I think a lot of people can go up the first position as well, and we can have minus 30 also. So I think this is the time which we can be. Hopefully this will go to the wire. So again, this is a buzzer round. And buzzer round, I think what we need to do is that we'll go to the chat. I'll share the details again. So audience question is there. I think this may be the last audience question. 12-year-old boy with gynecomastia. What is the genetic basis and what is the treatment that we are looking at? So this child, what we are seeing here, something in the lips and also has got gynecomastia.
Can I answer?
So audience, already Dr. Vignesh has answered Carney complex. So this is the different Dr. Vignesh, Dr. Vignesh Prabhakaran. So this is Carney complex. So now we'll go for the final round. The culmination of our quiz will be the buzzer round. So essentially every time I'll reset the chart, I'll write N. So I'll write N like this, which will be telling you that this is now restarted. All of you please write the Y to see if it's working. And as soon as you put Y, we'll stop. So we've got from Dr. Shyam, Dr. Mohit, Dr. Varsha, Dr. Salik, have you put? Dr. Salik we have got, and Dr. Mohit, everybody. So 1, 2, 3, 4, 5. So we've got from everybody. So +5, and there's no waiting, there is no pass, +5, -5. I think the rules are very clear. So let's start right now. And after 3 questions, you tell me the status. After that, we'll every question, we will look at the results. So it's like a one-day match or a T20 match going on, probably. 17-year-old girl with delayed puberty, stage 1 breast development, height is 154, BP is 170 by 100, FSH is 120. Dr. Shyam Sundar, no, who is given? Dr. Salik. Answer? Dr. Salik?
17-alpha hydroxylase hydrocortisone.
Hydrocortisone. So this is clearly 17-hydroxylase hydrocortisone. So I'll read
Sir, I was saying this answer, sir.
It
was on mute.
You were mute, and before that, the Salik had put it up before you, I think, just before you.
That was for the checking wise, sir.
Okay,
okay,
so it's fine. We'll give it 5 marks because, and you were on mute actually, so that was the thing as well. So anyway.
I think, sir, Shyam was the one first message, sir.
So Shyam pressed it first, and you had the same answer?
Yes.
Shyam, you had the same
yes,
answer?
Sir. 17-alpha hydroxylase and steroids as treatment for hypertension.
So I think we give it to both because that's very good. I think its sportsman spirit has been shown. So I think this is good. So now we have put N. So now I think it will be clearer. There will be no confusion there. 14-year-old boy on routine testing. Blood sugar fasting is 130, 2R is 210. Lean, no ketone. Glibenclamide was given. Immediate hypoglycemia happened. At blood sugar of 170, urine glucose was positive. I want the specific diagnosis. Salik. Dr. Salik, you're muted.
MODY type 3, HNF1A.
Okay, good, because there is renal glucose urea, threshold is affected. So +5 for Dr. Salik. So HNF1-alpha we're looking at, yeah. So I'll put N again. Now, the next question, so be ready. So you've got 2 questions already done. We'll check the scores at 3rd question. The next question is 10-year-old girl with thyroid swelling, multiple nodule, largest is 2.4 centimeters, TSH is 3.4, TPO is negative, FNA is category 2. Dr. Mohit, I think, has put the answer. So you have to answer quickly.
Dicer.
Dicer defect. Very good. So this is a Dicer defect, multinodular goiter with pleuropulmonary blastoma in the family and ovarian cancer. So I think this is a very good answer. So 5 marks to Dr. Mohit. So we'll come at the score at this point of time. Come on.
Dr. Varsha has scored 25. Dr. Mohit has scored 35. Dr. Shyam Sundar is heading with 57.5. Dr. Salik has 55 and Dr. Vignesh has 20.
So it's a very close fight that we are having now. So after every question, we'll have to come back and see the answer. So it's a very close fight. Now going on, I have reset it again. There are 3 more questions. So I think all of you should go ahead and try for this. This is Dicer syndrome. 15-year-old girl with obesity. Weight is 110. BMI is 44. Has ALT of 84. Shyam has answered. What are the constituents of agrissima?
GLP-1 agonist and amylin. Liraglutide and amylin.
Liraglutide and amylin.
Semaglutide and amylin. Semaglutide and amylin.
And not amylin. If you tell me what is Cagri, I'll give you the marks then. Because that is, I agree, sema is semaglutide. So amylin.
Cagri is amylin's analog. Okay.
Okay, what shall we do? So you said liraglutide and that. Okay, the correct answer is actually cagristema is a combination of amylin analog and GLP-1, which you are right, semaglutide and caglintide. So liraglutide was a bit wrong. I don't know what. No, there's like 0 or the other way around. So we'll probably not give any mark. We'll not cut also, but we'll not give you mark because it was partially correct. So it was like Ardha Satya sort of a thing. So I think we'll keep it at that point of time. So, so I think 2 more questions to go. Again, the gap is only 2.5. So I think both of you should go and try to answer these questions. I'll reset again. Anybody else has a chance of getting into that? Who is at 3rd? 35. So I think it's a fight between Salik and Shyam, and both of them have shown very good, basically, sportsman spirit as well. So we will hope that there's 2 questions left. We'll go from there. 4-year-old boy with failure to thrive, polyuria and rickets, phosphate is 1.6, PTH is 34, urinary calcium to creatinine is 0.8. Dr. Varsha has, no, Vignesh.
Is it CLCN5?
Okay. In the
And
setting
it's
of commonly known as? Okay, that's fine. But most people will remember the other one, the Crohn's disease. So this is correct. So I think we'll give you 5 marks. So now we have got only last question left. And there is a 2.5 difference between Salik and Dr. Shyam. So I think this is there. If somebody else presses, Dr. Shyam automatically wins. If both of them press, so I think it's up to them to decide about that. So it's an interesting scenario. Let's see how it goes. I'll reset it again. And the final question of the quiz is this. 6-year-old girl with severe short stature, height is -5.3, screening workup, Dr. Salik. Yeah, Dr. Salik, unmute yourself.
No, I took the chance. I'm just reading the question.
No, you can't read the question now. You have to answer it quickly.
Yeah.
Quick. Because if we stop the question, I'll stop the slide as well. So if you give me the answer in 3,
yeah, it's recombinant IGF-1.
Okay, that's correct, but you should actually not. Okay, so problem with the slide was visible, so you can answer that, but I think that's fine. So you've got 5 marks. So before we had the final scores, we will have the final, I think. Okay, so we already have IGF-1 as the answer. And the audience question before the results comes in, 12-year-old boy with headache, diagnosis in the most common endocrine manifestation. So anybody would like to put this one, the diagnosis and management? DI, so this is craniopharyngioma and DI. So I think the point is there. So we'll go for the final score. We didn't need the tiebreaker, I think. The final score.
So after the end of all the rounds, we have Dr. Varsha at 25 points, Dr. Vignesh at 30 points, Dr. Mohit at 35 points, Dr. Shamsundar at 57.5 points, and Dr. Salik at 60 points.
But I think overall, there have been the quizzes are there only for more of keeping it stimulating and to make it more interesting from that perspective. This quiz was really went to wire in that regards. Dr. Shyam was unlucky in a couple of scenarios, like Agrissima was one scenario, but he was lucky because Salik told in one question that he had given, so we gave him 5 marks on that. So I think balancing out, this was a very good, interesting quiz. One thing which I was pointed out was that Shyam did not get a direct answer question as well. So I think pretty much I would say that this was a wonderful quiz and all of you have done very well. And I would say we can probably think of both as a joint winners because of these so many confusions in that perspective. Somebody has to win on that perspective. But anyway, this has been a wonderful one. So we'll go forward. So the award will be the same for both the ones. Maybe the ranking, whatever we have to say, 1 or 2, the awards will be the same. So we'll start with Salik, your feedback.
Sir, it was a wonderful opportunity to participate again. Last year also I was part of the advanced quiz. And it was very much happy that Shyam is actually my junior in CMC Vellore. And it was a pleasure to share with him. And it was very good learning experience, sir.
Okay, thank you, Salik. And Shyam were doing very well, and you did excellent even in the prelim round as well. You had the highest score, I think. So that's good. So your feedback?
Yes, sir. So this quiz was actually very nice. So every time I've just been an audience. So this is the first time I'm participating. And as Salik sir is there, he's always who is. Yeah. It was nice. The questions were good. The newer ones were new. Yeah. It was very clinical. Even the prelims, like all the questions were clinical. It was very good to see such questions that we see in the daily OPD. And the questions were like that. And the finals was also very competitive.
Thank you. Thank you. Dr. Varsha?
Sir, it was as usual, it was a very brainstorming quiz, although I lost, but it was, I learned a lot of new things from this quiz, and we surely need to be updated all the time.
Okay. Thank you. Dr. Vignesh?
Yes, sir. It was very interesting. And last year I was participated in basic endocrinology course. So this time in advanced
You have
endocrinology course.
really evolved quite well. So I think that was good. And
Yes, sir.
Mohit? Dr. Mohit?
Yes, sir. Sir, it was like very stimulating, and the things and scenarios and updates we don't see like in day-to-day basis. So very informative and very enjoyable, sir.
Thanks a lot. So I'll thank all of you for joining, and we will be sharing details. Our team will contact for the winners and all the finalists about the ways to go forward in terms of the awards. I'd really like to thank Dr. Kirti and Dr. Ria, who have been here all the time and who have been responsible also for prelims round as well. Dr. Nimisha was also involved. Dr. Sayan also was involved. So it's a very extensive one, and hopefully we'll continue the same over the next years as well. So again, thanks everybody and all the audience who has joined us across in Zoom as well as YouTube. A lot of people are there. So we will close at that point of time, and thanks everybody and best wishes to all of you. because in life, it's not quiz, it's the case who will come to you and we have to answer, and you don't need to be absolutely right on the first go. If you are ready to accept that you may be wrong and you can open it up and change it up, that is what we want to do, to stimulate the mind. I think that's the point. Okay. So we'll close at that. Thank you. Thanks.